described, but you are reconstructing the length of that patient, the offset, and you have many regular hip replacements that do not even know they have a hip replacement. So part of that is trying to mimic the patient. So I wouldn't necessarily say that you're loading differently. You're loading right through the interface. With a resurfacing, you're loading from the cup to the big head of the resurfacing, and the same thing that you're loading through the cup to the head of the total hip replacement. That's where the loading is coming through. You're implying that the loading is coming into the canal. It's not doing that. Once the prosthesis grows, the bone grows into that prosthesis, it's become osseous integrated.
Okay.
That's been taken out of the picture. So now the loading, you can say, is just coming, whether it's a resurfacing from the interface that you're moving from, the joint itself. I don't know if that explains it well. I probably should, if we do this again, in my hands I should have a hip replacement device and a resurfacing device, and I would be able to show you this a little better with the devices to explain myself. So I don't know if that's as clear as it can be from my description, but sometimes showing a demo, that's much better. Did that explain it to you a little bit?
Yep. And what is the common material, like the total hip replacements? Are they also cobalt chromium?
No, some of them. The one I use is an alloy of titanium, cobalt, chromium, molybdenum. And then for young patients, I will use an alloy of titanium, put a ceramic head, and then that'll interface with a polyethylene. So it's somebody like you, the interface, which is where you're loading, the metal head of the total hip replacement into the plastic, or in a young patient like you, the ceramic head is, so the articulation is where the wear may come. So in that scenario, I'm not worried about people with metal allergies I don't remember, what did you say was before tin or whatever. There are people that have allergies to metal. I'm worried about what is articulating, and I can take out a metal articulation by having ceramic articulating with polyethylene.
Yeah. In
those scenarios. And that's what I would recommend that anybody that thinks that they potentially could be allergic, which is not that common, but it's more common in women that are they wear jewelry a lot more, they're sensitized more to the different metals that they're wearing, and we don't know if that is a total correlation between skin hypersensitivities and systemic hypersensitivities. I'm not 100% sure there is a correlation, although we got to be a little wary of that. So just because somebody may be allergic from their skin to certain jewelry or metals doesn't mean they're going to be allergic to a metal device in their body. But in this situation I'm describing, you're shielded from it because where the parts are moving are not metals. So that to me is a good solution for a person that is concerned about a metal allergy. All right, so let's go, and we can continue that offline if you wanted to email me on this, because these are nice questions and they're interesting. Some of them take a long discussion. So the question from Larry P. I had a posterior approach on my resurfacing. Does the gluteus medius muscle get disrupted? Also, will an MRI catch a gluteus medius tear? Just trying to throw something out. Why your resurfacing had issues one day to the next, although 10 months. So typically with a posterior approach, you're not going directly to the gluteus medius, or minimus for that matter. You are going very close to the gluteus maximus, but it can get tugged. You may not be going that way, but you may be pushing and pulling muscles, and they can sometimes get damaged. But in addition, there are people that have arthritis, and there is a percent of people that may have gluteal tears. And in some studies, it's usually in older patients, 10 or 15% will have these chronic tears. And unless you're looking for them, you may not even see them, and they need to be repaired when you're doing your hip replacement. So if you're at 10 months, and we would like to think that at 10 months people are much better, it's not everybody. So then that's where you want to, and again, I don't know the whole situation, but based on what you're telling me, that might want a workup, and you might want to get that MARS MRI, the metal artifact reduction sequence MRI, and by that MRI taking out the metal, you can actually look at your soft tissues and examine the gluteus, glutei, or any of the other soft tissues and see if that might be an issue. So that might be something that you can do. But again, you're the type of person that I like to see exactly what's going on, what's hurting, can it be rehabbed, and make decisions about where to go on workup. So you need practitioners that really want, they really examine you carefully and really listen. Sometimes people are very complex. They don't even have one problem. They have like pain in 3 or 4 areas, and you have to figure out which is the primary thing causing them a problem and which are the secondary and the tertiary, and they occasionally do have 2 problems at once. Sometimes I can use in my diagnostic acumen, I can inject certain areas with a local anesthetic. Sometimes I use a corticosteroid for certain scenarios, but with a local anesthetic, I can inject an area, wait a few minutes, and if their pain is gone, then that area may be the part that's hurting them. So that's another way to try to figure things out. Minimal, a minimal thing like getting a needle, but really can help you figure out and diagnose things. So I'm keeping this a little generic, but many people that would be on a site like this that have had a resurfacing are trying to get their questions answered, like, why am I still having problems? Why is this going on? So that's that demands a whole workup of the patient that starts from hearing the history, examining them very carefully, then looking at the x-rays, and then deciding, do you need other tests? But don't necessarily jump into the other tests, because sometimes the diagnosis is right there for you. So that's just a general answer. I hope that helps Larry and P a little bit. Who else? What other questions here?
We missed one.
Do I always recommend a resurfacing over total hip if the patient meets the criteria? And I don't, that's a loaded question. What's the criteria for hip resurfacing? And different people have different criteria. My criteria is a little bit, people get to know me, and when I start doing chats like this, the ones that want to get a resurfacing may learn what to tell me, but to get their resurfacing, which, I mean, I can't control for that. But I generally want to do resurfacings on younger patients. So these are typically men under 50, but again, I don't go by that because I've had 65-year-old champion tennis players. But in a general sense, patients under 50, don't like to use age as a sole factor, that are men, and I like women that are post-gravida. I have had women that have had resurfacings, and we've had at least 20 or 30 women that have had babies afterwards. But most of the time we'll wait. They're women that have already had babies. But that's a whole nother discussion to get into about timings and things like that. But in both groups, I want generally people that are very athletic. I don't see the total use of a resurfacing if somebody's going to be sitting at a computer all day and they're very sedentary. And why do I say that? I think that A resurfacing in a reasonably well-active patient can last 20 or more years. They're keeping, who was it, Catherine, that talked about keeping your bone stock? I think if you're keeping active and you're maintaining your health, then you're going to maintain your bone stock, and the femoral neck around the resurfacing will be maintained 20 years or more later. If you are sedentary and you become a couch potato, or you don't keep your diet well, and you lose your calcium, and you become osteopenic, then that femoral neck can thin. Right? It's not being loaded the same way. Or somebody's becoming osteopenic as they get older, and then they can be susceptible down the line to a hip fracture. In a total hip, they're not susceptible to that same hip fracture that I'm talking about because they've had that femoral neck and hip removed. But in a resurfacing, you still have your bone. So in a population of 100 patients that are all athletes when they're 45 years old or 50, when they get their resurfacing, how would I know of those 100 patients what will happen in their future life? Let's say 95 of them, by the time they're 70, are still athletes. There still could be 5 of those patients that have a medical illness in that 20-year period. They become high blood pressure, they get sick, they have a renal thing, or different things happen to people. They get into an accident or something, and they're more sedentary. So if you want to look at a population like that, or if you want to look at 100 patients or 1,000 patients, there will be some patients that down the line do end up becoming osteopenic, but you don't know that ahead of time. So when you get a resurfacing, you hope you're going to stay healthy and active and everything like that. If you knew down the line you were going to become sedentary and you might have an illness, then of course you would get a hip replacement, because it wouldn't matter. You can get a hip replacement and your bone stock doesn't matter. As I said before, the cortex remains, and you're not worried about a hip fracture down the line. So that is what I just went through is pretty confusing, and I may not have explained it very well, I guess. But it's a reason why people getting a resurfacing, it's a little bit of a gamble that you are gambling that you're athletic and you're going to keep your health and maintain your calcium balance for the next 20 or 30 years. And if you're doing that, it's a great approach. Not knowing the future for anyone. And I think it's a good gamble, because many of us that are young and healthy at age 44 or 45 are going to be that same way at age 65, and then it's worth it. So Pat, did I explain that well? Does that make sense?
Yeah, you're scaring me. I'll be 74 and I don't run around as much as I used to.
Well, you're still getting around and you've done well.
I am.
And if you are, so the other thing to not scare a Pat, is I'm giving a general overview, which I'm maybe talking too much here. Pat is not somebody sitting in bed because she's sick and then the bone is sleeping
No.
and she's going to be very osteopenic. She's still reasonably active. But if there's any concern for a Pat who's had a resurfacing for 20 years or more, then she gets an x-ray at a certain interval and she looks at it. And we compare the x-ray to the previous one and said, we're not worried. But Pat's only like 57 years old. But anyway, no. As we all get older, into our 60s, whether it's more common in women, but as men also, we have to be concerned about our bone stock and keeping our diets well. I went to Cleveland. I'm now back in New York, and I became vitamin D deficient. I didn't even realize it. I couldn't believe it when I got tested, because there's not that much sun out there. It's only like a few months of the year, and I was indoors all the time, big institution. So I'm right now taking vitamin D pills every day, but I think I'm getting in the sun more, and that's that. So we all, as we get older, as we're 60 or 70, we can be susceptible to getting hip fractures. There is a high incidence of hip fractures in patients over 70, and I'm obviously an orthopedist, and I'm rah-rah, keeping joints preserved and bones preserved, but the best, and the importance of what we do in orthopedics. But one of the main things I can say is that trying to avoid hip fractures and keeping your bone stock well and avoiding falls and things like that can really prolong your life. Okay, there's a high mortality for everyone for people that are over 60 or 70 that get hip fractures. Despite what we do, we fix them right away. It does lower survival. So anyway, all of that applies to resurfacing where your hip is left. So I guess that's comes full circle. That goes for all of us with our hips in place. We want to avoid falls. We want to keep our bone stock together, especially with a resurfacing over a standard total hip, so we're not susceptible to fractures. Okay, any other questions here?
You might mention with the resurfacing, it is easier to get your revision, and sometimes you can keep your same cup.
Yeah, I mean, I have found it is a very straightforward revision. That's one of the main reasons, and I'm going to wave my hands, that I'm an advocate, because, you know, people like getting resurfacing, and they can be active, and that's their feeling about it. Even if it's one choice or the other, get a resurfacing or total hip. If a revision is needed on this marathon runner, it's straightforward. Now, there were one or two reports where the results weren't as good with revisions, but in really examining those reports, in my opinion, this is my opinion, they didn't do the revisions right away, or they waited on these types of things. And the patient might have had symptoms for a long period of time, and that made the revision harder. But the revisions that I have done for resurfacings have been very, very straightforward. Again, there are tissue reactions that people wait too long. That can make a revision much harder.
And Dr. Mont, when you do that revision, are you sometimes doing it as a hip resurfacing revision, or are you converting it to a total hip replacement?
I mean, there have been some cases that I've done a hip resurfacing revision where they're unique cases where I was able to change a cup around. A cup moved around, and I put a new cup in, and I was able to get this new cup in. There were cases where there was a fracture, but I was able to save the resurfacing by pinning around the fracture. But most of the time, there were other cases where we left the resurfacing femoral part, or you left the cup part. The cup was left, and then we mated that with a total hip. So we were able to leave half of it. But most of the time, these are revisions to a total hip. Those are just what you asked me. There are rare exceptions where I've been able to save a resurfacing, but they're unique things, and they're more fascinomas or different strange scenarios that happen to patients. Most of the time, if something fails, it gets converted to a total hip.
Okay. Thank you.
Yeah, I would like to thank everybody. I wish we had more people. I did not email the 5,000 members of the HIP discussion group. Next time I will. This was our dry run to see how it's going to work. There will be, I have recorded everything. It automatically happens, so I will post that. So if you want to go back and you can listen. So I want to thank everybody and Dr. Mont for taking his time, and hopefully we will do this again.
And by the way, I see one more comment there. I was in Cleveland Clinic, as I told everybody, for about 2 years, and Dr. Brooks is fantastic. He does the great bulk of the two of us were doing the resurfacings there, but he has tremendous experience, and I would highly recommend him if that's the question there. So from direct personal observations and experience, and he's the person that I'm writing a number of papers with on resurfacing. That will be coming out in the next few years. So anyway, I want to thank everybody. I think this was, in a way, Pat is saying it's a dry run, but another way it was almost like a personal way to talk to a whole bunch of people. Hopefully got most of everybody's questions answered, rather than a larger group where we wouldn't have been able to, we probably would have had to do these questions a lot quicker, and we're able to talk a little bit more now. So I want to thank Pat for not only this, what she put together here, but what all her unbelievable efforts that she's done for resurfacing in patients with hip problems for such a long period of time. So she really deserves praise, and I can't thank her enough. So, thank you, Pat. Thank you, everybody, for the great questions. I hope this was helpful.
That's why I do it, to help everybody.
Yeah.
You need a source to be able to learn, and there aren't many sources. Thank you, everybody.
Thank you very much.
People again.
Okay.
Thank you. Thank you very much.
You're welcome.
Good night.
Good luck, everybody.